like this tends to be somewhere midway between the two, the milder form and then the more severe form. So chronic suppurative lung disease refers to the clinical syndrome, we'll talk about it later, of the symptoms of chronic endobronchial suppuration. And in this case, you don't have any radiological evidence to show dilatation of the airways, that is bronchiectasis. So the patient has chronic cough and all the other symptoms, but you haven't done a CT scan yet to prove that there's bronchiectasis. So in that case, they are usually termed having a chronic suppurative lung disease. Then when you have at the far end of the spectrum, you have bronchiectasis. So this is bronchiectasis is actually a pathological or radiological diagnosis. You can only diagnose it when you see it on the CT scan, that the airways are dilated, either cylindrical or cystic, circular, as you see it on the X-ray. So that is when you say the child has bronchiectasis. So once you've not done CT scan to see those changes, usually you put them under the umbrella of chronic suppurative lung disease. Okay, so we'll move on. So just look at a bit of pathophysiology, because the main underlying etiology is the fact that there's a defect in the lungs, the host defense in the lungs. Okay, so this human body we have has an intricate way of defending itself from various pathogens and infections, and the lung is not left out. So in our lungs or in the respiratory system, we have various mechanisms the body puts in place to prevent like antigens or bacteria from colonizing us and causing infection. So even in quote, normal cough is a protective mechanism that the body puts in. It means there's something irritating the airway that has to come out. So the body is trying to cough it out or get rid of it. Other things like the epithelial lining in the lungs. And you can see in this picture, these tiny hair-like things. Okay, they are called the cilia. They line the whole of the conducting airways right down to the terminal bronchioles. So all this cilia and the mucus on the surface, we call it the mucociliary apparatus. So all this helps to protect the lung. So the bacteria or other antigens that land in the lung will be trapped in the mucus, and then the cilia will just brush it. It has a particular way of moving to brush all this mucus with the trapped, whatever is trapped in the mucus, sweep it towards the upper airway so that the person will cough it out. Okay, and then apart from this, you have the cells, macrophages, neutrophils that come in when there's an infection. All these things are going on in the lungs. So when there's a defect in any of these things, it means bacteria can land safely and start colonizing and then causing inflammation and all that. So when we talk about chronic suppurative lung disease, the defect underlying is actually a vicious cycle that is occurring. So it can start from either point, okay? And what happens is all these factors interrelate, okay? And then it becomes like a vicious cycle. So you can have a child who has a primary problem that affects how he clears his mucus. So the mucus is not cleared well, bacteria stay there, they cause infection, and then damage the airway, breaking down the tissue, and then the body is not able to repair it, so it becomes dilated. Mucociliary clearance is still impaired, so bacteria keep multiplying, causing more inflammation, causing damage. So it just keeps going round and round and round, a vicious cycle. So knowing this underlying pathophysiology is what helps us to direct the therapy, to be able to break the cycle at any of these points so that it doesn't keep going round and then it's like a self-perpetuating cycle. Okay. So as I mentioned, PSLD is a clinical syndrome. What you mean by that is you have a number of symptoms occurring together. So the main symptom by far, up to about 100% of all children who have a chronic suppurative lung disease will come with chronic cough, chronic wet cough. So I want to stress on it, it's a wet cough, not a dry cough. So this child, or if it's an older child, they'll have chronic cough and they'll produce a lot of spitting, purulent spitting, green, yellowish, or sometimes brown, depending on whatever is going on down in the lungs. So the main feature is a chronic wet cough, okay? And they have recurrent chest infections. So they have, you can usually get a description like the child has like ongoing daily cough, everyday coughing, small. Then there are periods when the cough gets worse. Okay, so they get recurrent infections. When they get a new infection, the cough gets worse, they produce more spitting. And then usually when you give them antibiotics, they'll respond. So if you give them, like, let's say 3 or 4, 5 days of antibiotics, you see that they feel better, the cough will come down, it's like they've come back to baseline. You have small cough every day, and you have another infection, and then the cough will go up. So if you pay attention, sometimes these kids can be falsely diagnosed as having asthma, and then those infectious periods will be termed as having an attack. But when you go into the history, you find the mother saying, or hospitals, like they give antibiotics and the child is fine. But we all know asthma is not treated with antibiotics. So when you have these kids, you have to be thinking of some of these things. So when they come with chronic wet cough, and you hear some of these things, you should be thinking of, is this child having a chronic suppurative lung disease instead of the asthma he's being treated for? Okay. So other symptoms or signs you can find in a child with CSLD, apart from what I've mentioned, they can also have growth failure. That is when this goes on for a long time. Okay, it impairs their growth. As the disease progresses, there's damage to the lungs. It affects their lung function, and they become tired after minimal exertion. Okay, and then as the disease keeps progressing, you find that they'll have digital clubbing and then chest wall deformity. So a bit about epidemiology. As I mentioned earlier, this condition has been with us for a long time. Okay, and I think the discovery of antibiotics came in 1920 something. So before this period, people had this condition, but antibiotics were not available. So when antibiotics came in, it sort of improved the outlook of the condition, and it became like a forgotten disease. So most papers will describe bronchiectasis and chronic suppurative lung disease as a neglected disease, because it makes sense that once antibiotics have come, the disease should improve. But you can all see that that's not the case. Okay. Actually, worldwide, they've seen an increase in the number of cases being reported. And this can be due to several factors. It can be that now people are becoming more aware. CT scans are more available, so people are taking CT scans, and we are seeing it more often. And now, because of the long-term effect it has, people are actually starting registries to be able to recruit these patients to study and then find the causes and interventions for this disease. So we are seeing a spike in cases, more so in middle-income countries like ours, where we have a lot of infections. The burden is high. Unfortunately, we don't report or gather a lot of data. So data from our part of the region is lacking. It's ironical because we have the high burden of infections, but we are not reporting our cases. So we don't have data to support, but we know that it's, the incidence or the prevalence here is high. Even in high-income countries, in affluent countries, those with in poverty, economically disadvantaged populations, they have high burden of the disease. Okay. So as mentioned, data in our part of the world is very scarce. Now, people are getting aware, more data is coming up. So this data from Nigeria was as far back as 1982. They found out of 1,050 patients, it was 14.5% prevalence. And then this was more recent in 2019 from South Africa as a retrospective folder review. And then they found a prevalence of 17.2%. Okay. And the average diagnosis was at 3 months. So it's a condition that is common in children. And I want to keep stressing that any child you find with chronic breast cough, you should pay attention to the child because as the other presenters will talk in their session, identifying them and initiating appropriate interventions can go a long way to improve their lung function and then reduce their risk of long-term morbidity. So we'll talk a bit about the etiology. And by far in our part of the world, post-infectious causes are the most common, particularly pulmonary TB. Okay, we know that in young children, the presentation of TB is usually a lymph node disease, and the lymph nodes can cause compression to the airways, and then the airways being compressed means there's decreased clearance, the mucus will sit there, and the whole cycle will be perpetuated. So children with PTB are one of the cohort of children that we should be really following up, because post-treatment of TB, we tend to, we diagnose TB in the kids, we put them 6 months treatment. When they finish, then they are lost in the system. But actually, these are kids that we need to keep following up, because post-TB treatment, we can still have complications. Okay, the typical scenario is you have a child has been treated for TB 6 months, and then let's say 2, 3, 6 months down the line, the child comes back coughing, sputum production, not gaining weight, and then the X-ray looks doesn't look okay. Then someone will put the child back on TB treatment, even when you go and check and TB is negative, because we all know the other challenges. Diagnosing TB in kids is also a challenge. So these kids will get repeated courses of anti-TB, but most likely they're having complications from the initial TB. So we should always think about this, like post-TB lung disease, bronchiectasis, and then manage appropriately. They may not need to have another course of TB. It's just a consequence of the initial TB that they had. So PTB, very common in our setting, and it's one of the most commonest causes of chronic obstructive lung disease. Other infections, adenovirus, measles. Measles has a tendency to knock off your mucociliary clearance and then put you at risk of getting severe pneumonia as well from other bacteria. Okay. So children who have pertussis measles also are at risk, or it's a cause of chronic obstructive lung disease. And any child who has recurrent or severe lower respiratory tract infection, and as we mentioned earlier, protracted bacterial bronchitis at the earlier end of the spectrum of the disease. So based on what we discussed in the pathophysiology, we can deduce some of the causes of this condition. So children who have immunodeficiency states, more commonly in our setting, HIV, so that's secondary immunodeficiency. And we know HIV and TB always go together. Okay, so there are many cohorts of children that we need to be following up and then assessing them for signs of chronic obstructive lung disease and then instituting management. Other immunodeficiency states, the primary immunodeficiencies, immunoglobulin deficiencies, and neutrophil abnormalities also at risk of bronchiectasis and chronic obstructive lung disease. Children post-chemotherapy on immunosuppressive therapy, the underlying problem is they are immune suppressed, prone to infections, and the infections will lead to damage to the airways and then put them at risk. Again, children with structural abnormalities, looking at the pathophysiology, tracheomalacia, bronchomalacia, all impair mucus clearance because there's obstruction, and then the escalator also doesn't work well. And I also want to mention children with foreign bodies. So these children, usually if it's due to a foreign body, a foreign body will go and lodge at a particular place. So when you have a child who keeps coming with pneumonia, and every time you take the X-ray, it's the same spot that is having the pneumonic changes, you should think about maybe a foreign body that has been missed, because early intervention can actually save that lobe that is affected. So you should always think of foreign body when you have a child. Maybe we didn't get the history of him inhaling or choking on something, but when you keep seeing the child keeps coming with pneumonia with the same side being affected. It's something you should think about. And then children with other congenital abnormalities like a CPAM, cyst sequestration, they also have problems with clearing and then risk of infection. So they can also get chronic suppurative lung disease. Sorry. And as mentioned earlier, the impaired mucociliary clearance, these conditions are not common in our setting, but we also have to look out for them because we've had a few cases of cystic fibrosis in Ghana. So it's not too far-fetched, but in our setting, these are not the conditions you go and look for in the beginning. So we look for infections first, and if we are not finding it as a etiological factor, then we come and look at these other rarer conditions because they are not very common in our setting. So for PCD, cystic fibrosis, there's a defect in the clearance of the mucus and then the nature of the mucus itself. Children with neuromuscular conditions, they have weak muscles, so they can't cough well. Okay, so the mucus sits there and then it becomes a breeding ground for the bacteria to multiply. Okay, I'm coming to the end of my talk. So I just want to give a few summary key points. Importantly, we need to recognize chronic wet cough in children. Okay, so maybe we should go back. The children who keep coming with asthma and cough, 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 they don't seem to be responding to your inhalers. And the mom will give you a clue that, oh, call hospital, a man among the club, none of okay, you should go back into your asthma cycle, reassess, does this child really have asthma? Because these are the children that will be deemed like difficult to treat asthma, but it's not really asthma you're treating. There's something else. Asthma will not usually give you a wet cough. So any child with wet cough, you have to pay attention. And as I mentioned, in our setting with the high burden of infections, children who are treated for PTB, and then especially in the context where we have HIV also, we have high numbers that are at risk of developing this chronic suppurative lung disease. So as I said, think of PBD, chronic suppurative lung disease and bronchiectasis. And then the other two speakers will talk about investigating and managing. So once you diagnose it or you suspect it, you need to investigate appropriately and then manage them as well to improve their long-term outlook. So I want to end here and then give you for the other presenters. I'm not sure if we'll take questions now or we'll take it at the end of the whole presentation. I want to thank you for your audience.
Thank you very much, Naomi. Thank you very much. Dr. Kwating, please, are you able to continue to moderate? Okay, I think she mentioned that should be off for a while. So Naomi, thank you. I think we'll take the question and answers at the end when the other two have presented. So we would now call on Dr. Sarah Modri to take us through investigating a child with chronic suppurative lung disease. Thank you.
Hello, good evening, and thank you very much for the opportunity. Just tell me if you can hear me, please.
We can hear you.
Okay, great. We are talking about investigating chronic suppurative lung disease. And the main thing that I want everyone to take away from this presentation, this portion of the presentation, is that I want everyone to be able to state 4 tests to do in suspected childhood bronchiectasis. But before you investigate, I want to say, as Naomi, just lay emphasis on one of the things that Naomi said, which is that chronic suppurative lung disease, especially bronchiectasis, is a clinical syndrome. And then when you think about it as a clinical syndrome, you realize that there must be certain symptoms or signs. So before you investigate, you must be sure that you have a history consistent with bronchiectasis. This is because bronchiectasis is a radiological diagnosis, but as we go on, we will see that it is not a very perfect way to diagnose bronchiectasis. Therefore, before you embark on investigation, you must be sure that you have a history that is consistent with bronchiectasis. And to also tell you to involve a pulmonologist right from the beginning. The pulmonologist doesn't have to be in your facility. You don't need to know the pulmonologist. You can send a message, call the pulmonologist. The reason is because some of these tests are very expensive. They are very specialized. And so if you involve a pulmonologist right from the beginning, it is more likely that resources will be used in a more rational way. Why do you want to investigate? First, you want to confirm the diagnosis. If it is truly bronchiectasis, you want to determine if it is localized or it is generalized, because it has an impact on how the child is managed. You want to determine the extent of disease. You want to identify underlying factors, because some of them may be treatable. And so if you are treating a child with bronchiectasis without treating the underlying factors, what is happening is that you are just firefighting, and as long as the underlying factor is untreated, the cycle that Naomi has described, the vicious cycle, mucus production, and it stays there and it's colonized and so on, will keep on going, and then you will not be winning. So to confirm the diagnosis, the test that is most readily available to all of us is a chest X-ray. It is not too expensive, but if the child has advanced bronchiectasis, then you can see it. Otherwise, sensitivity for bronchiectasis is quite poor. However, if you are trying to distinguish between protracted bacterial bronchitis and bronchiectasis, sometimes it may be useful, because you see that in PBB, the chest X-ray is completely normal. You don't have any radiological features. A chest X-ray may also be helpful to rule out differential diagnosis. So perhaps it's not a chronic suppurative lung disease. Maybe it's an acute thing, an empyema, or it's just a pneumonia. A chest X-ray may be helpful in such circumstances. So the chest X-ray that you see on the screen, which is to my left, it shows this is a teenager, actually. I think she's about 13 years, and she's got advanced bronchiectasis of the left, distraction of the left lung. And then when you look at the upper lobes, you see a lot of cystic dilatation that is happening there. You see that because she has lost lung on the left, the mediastinum is furthermore shifted. The right lung is moved to the left to try and compensate for the loss in volume. But you can see all these dilatations there. So that is advanced bronchiectasis, and that is why you can see it on chest CT scan. This child actually has post-infective bronchiectasis. It was adenovirus that caused this. And then this sagittal CT, the child actually has a chronic pulmonary airway malformation. And then when you look in the lower lobes, you can see that bronchiectasis is just starting. So what you see here, not very well defined, is what we call the signet ring. I will show on another view. But this is a child with a CPAM and then has got early bronchiectasis. So this axial CT is showing advanced bronchiectasis. Please forget about the arrow. I couldn't remove it from the picture that I have. And you see the dilatation that Naomi is talking about. These are the airways. They are not supposed to look like that, okay? But there's a lot of dilatation that you can see. And this is what I was calling the signet ring, like the ring that most of the ladies wear a ring and there's a stone on top. But this comes from when rulers used to wear rings that they used to I think it was used as a stamp or something. So you see the hole, which is the ring, and then like if you liken it to your wedding ring, the one with the stone, there's a stone on top. Yes, that's a signet ring sign. So in a normal lung, you are not supposed to see the airways looking this big. You definitely should not see this kind of signet ring picture. And also, usually, you don't see the bronchi as far close to the pleura as this is showing, but here you are seeing them here. So that is bronchiectasis. So just to say a few things. So what you use, the definition of bronchiectasis is defined on high resolution CT scan. When we say high resolution CT scan, it simply means that a CT scan of the chest, but the slices are very thin when they are doing the reconstruction. So it's very important that when you are ordering the CT scan, you either request for a high resolution CT scan or you give a very detailed history to the radiologist so that they will be able to choose the right test for you. Because if it's not a high resolution CT scan, that is not the right test for diagnosing bronchiectasis, and you may not find what you are looking for. So on CT scan, you have bronchial dilation. And bronchial dilation, you know, in the beginning, I said that you must investigate only in the context that the child has symptoms and signs suggestive of bronchiectasis, okay? Bronchial dilation is the size of the bronchioles in relation to the accompanying arteriole. So what happens is that it's a bronchoarterial ratio. What happens is that in bronchiectasis, when you do, you divide the inner diameter of the airway over the outer diameter of the arterioles, you have a ratio of more than 0.8 to show that it is dilated. This is not the same ratio that is used in adults. The normal ratio is about 1 and above. But in children, because the airways are smaller, a different ratio is used because they are children. And we are saying bronchial dilation. So let's say you do a CT scan now and the bronchi are dilated. How do you know that it is not a temporary thing? Because in bronchiectasis, it's that the bronchi are actually dilated. Even though we know that in early bronchiectasis, you can actually reverse it. But the syndrome of bronchiectasis is like it's dilated today and it's dilated tomorrow. So it's not like a temporary thing, you see. So this is not a very good way of diagnosing, because the fact that it's dilated today doesn't mean that it is dilated tomorrow if you do the CT scan. But we don't go and be doing repeated CT scans. That is why it's very important that you investigate only in the context that there is a clinical syndrome. You don't go about doing CT scans for people if their history is not suggestive, because you may find things that you does not fit your clinical picture, and maybe you are giving a diagnosis to someone and it's not bronchiectasis. So we also have on the CT scan, you could have bronchial wall thickening, abnormal bronchial tapering. As the bronchi are coming close to the pleura, you shouldn't even see them, but in bronchiectasis, you see that the same ratio is, the same size is maintained all the way till you get to the pleura. That's an abnormal bronchial tapering. The bronchi should not be at the pleural surface. And so from these, there are some radiological scoring systems that have been developed, as, for example, the BALA score that you can use for the diagnosis. In most cases, the CT scan cannot tell you the etiology of bronchiectasis, but when the bronchiectasis is focal, it may be helpful to tell you, because when it's focal, you need to think about something happening in only that part of the lung. Let's say you have just a left lower lobe bronchiectasis or left upper lobe bronchiectasis. You have to look closely and see, is there a foreign body and those sort of things. So it's helpful to also tell you that this is a focal or a localized bronchiectasis as compared to a diffuse bronchiectasis, because sometimes in the focal ones, you may want to resect and so on and so forth. Then MRI. MRI is an imaging modality because everybody is concerned about radiation. MRI sees mucus plugging much better than a CT scan. Mucus plugging just means that the airways are filled with mucus and it's stuck there. But currently, it is still inferior to a CT. The best modality radiologically is a high-resolution chest CT scan. Then another investigation that you could do is bronchoscopy, because bronchoscopy simply means looking into the airways. So when you look into the airways, you can take a sample to help you to see if there's an infection and what organism you grow on culture for TB studies and so on. You can use it to diagnose aspiration when you do cytology, because the cells, you may have lipid-laden macrophages and other things that you may find that may not be directly related to bronchiectasis. And the bronchoscopy too will show you anatomical abnormalities. Naomi mentioned that you may have some tracheal stenosis, you may have tracheomalacia, and bronchoscopy can tell you that. And then you can do lung function tests. So lung function tests, there are many of them. The commonest available one is spirometry. Spirometry just helps you to eliminate some differentials, but also tells you the extent of the problem. And you can also use that to monitor the patient. If the FVC, the forced vital capacity is declining, most likely you are not weaning. There are other lung function tests we have, but I don't think we have them in Ghana currently. For patients with cystic fibrosis, the lung clearance index is much more sensitive than a spirometry. You begin to see changes much faster. For children who cannot blow, because spirometry is a forced maneuver, you have to ask the child to give the biggest blow they can blow. So let's say a 2-year-old or a baby cannot do that, and you can use the forced oscillometry technique, which doesn't involve much cooperation from the child. Then to investigate the etiology. So I sort of started at the middle, because in our environment, investigating the etiology may be easier than confirming the diagnosis, where you have to do a CT scan, because how many facilities have a chest CT scan? So the etiology may be historical. You may find it in history. Somebody may tell you that 3 years ago, I was treated for TB, right? Or somebody may tell you that their child was diagnosed with HIV, but then they stopped treatment at a point because of social reasons and they were uncontrolled, and then, yeah, those sorts of things. Or they may tell you that they've had many lung infections. Every 5 to 6 months, they are admitted with a lung infection. So the etiology may actually be historical. So it means that your history is very important. There is a minimum panel of tests that you should do for every child that you suspect has bronchiectasis. The first is the full blood count, which I'm sure 99.99% of us can do in our facilities. So on the full blood count, what are you looking for? Sometimes, like Naomi described, the child has a chronic wet cough. It's there all the time. But then sometimes the cough is worse, or they produce more sputum, or it is blood stained, or they have more fatigue, they have more fever. We call that a pulmonary exacerbation. And in those ones, the full blood count may show a high white cell count with neutrophils that are elevated, or even just at baseline, because bronchiectasis is a suppurative condition. Just at baseline, they may have slightly raised white cell counts. So you are looking for that. The other thing you are looking for on the full blood count is any evidence of immunodeficiency. So you may find that this child has a low white cell count, okay? Because we know that high white cell counts suggest an infection. Sometimes when we see a low white cell count, then we are excited. But the low white cell count is also abnormal. That may be evidence of a primary immunodeficiency. And then you look at the neutrophils and they have almost no neutrophils. That may be indicative of a primary immunodeficiency. So on your full blood count, you are looking for high white cell counts, but you're also looking for low white cell counts. And when you come to the differentials in the full blood count, you are looking to see whether any of them is low, because that may be indicative of a primary immunodeficiency. And then, as you all know, there are other things you can find in a full blood count, which may not be related to the etiology of bronchiectasis or chronic suppurative lung disease. So, for instance, if this child has been unwell for a long time, child may be anemic, or maybe they are too sick to eat, so they are anemic, or anemia of chronic disease. You can find those things, which may not be directly the bronchiectasis, but just the effect of having had bronchiectasis for so long. And then HIV tests, which again, I'm sure we can all do in our facilities. So HIV tests are part of the minimum. Okay, you don't discuss a child with bronchiectasis or refer a child with bronchiectasis if you have not been able to do an HIV test, unless of course it's not done in your facility. That one, nobody can quarrel with you. You must investigate for TB, because like has been said by the previous speaker, Our causes are post-infectious, and TB is one. But the interesting thing, which I have found in my practice, and that is what Naomi also spoke about, there are patients who have had TB. Sometimes it is actually presumptive TB, which is perfect. It's okay, because we know it's difficult to diagnose TB in children. Okay, not that we should just be putting everybody on TB medication, but sometimes it will just be presumptive TB. And this child has treated, you are sure of adherence and everything, and the child continues to cough, and it is a chronic wet cough. Then they start the child on TB treatment all over again. And then the next time they do the TB test, the TB test is negative, and they start the child on TB treatment all over again. We know that diagnosing TB is very difficult. So on your TB test, you may not find anything. If you find anything, is good, you treat for TB. But you don't find anything, and you know this child has been treated for TB already, unless you are thinking about drug-resistant TB. I think please move on with your other differentials, like thinking broadly, could this be bronchiectasis? And then you also need to do sputum microscopy and culture, okay? Because in bronchiectasis, in treatment, you find that we may use some antibiotics prophylactically, and you don't want to have an organism there that you haven't treated and put a child on prophylactic antibiotics. And then you also, you want to treat that. Plus, there are some organisms that when we culture, we are very suspicious of bronchiectasis. One of them is Pseudomonas. I remember in my hospital, there was this child, they didn't have money for a CT scan, the chest x-ray, child was on TB treatment, was an HIV patient, and had multiple infections, was now on TB treatment, presumptive TB treatment. And then one day we asked for a culture, and the child cultured Pseudomonas. Okay, already I looked at the x-ray and I was suspicious. Anyway, so when Pseudomonas came, I said, very likely this child has bronchiectasis. And when we finally managed to do the CT scan, the child has bronchiectasis. So some organisms that when you culture, you must think about bronchiectasis. And then if you read in the literature, serum immunoglobulins are part of the minimum panel of tests, okay? But for us in our environment, because they are expensive, at this point, I would urge that you discuss with, if not a pulmonologist, at least a pediatrician. Because you are looking for, you're trying to do the serum immunoglobulins because you are looking for primary immunodeficiency. If immunoglobulins are absent or very low, okay, that may be indicative of a primary immunodeficiency. Just be careful not to do the immunoglobulins when they are acutely ill, because some of them may be high as a response to the infection that is going on. Vaccine responses are also listed as part of the minimum panel of tests, but in Accra here, it's only so far from my engagement with various laboratories, it's only Noguchi that is willing to do vaccine responses for us. And what vaccine responses do is that we have the expanded program of immunization that we give all children to protect them. So in the vaccine responses, you test the response to all these vaccines because you want to see if any of the responses is absent or low. It means the child is not protected for that particular organism for which the vaccine was given. So let's say, which organism? Let's say strep, okay. Let's say, or pneumococcus. Let's use pneumococcus. Let's say pneumococcus. Everybody born after 2012 has received pneumococcus. So you go and do the response to pneumococcus and it is absent. Okay? That may be indicative of an immunodeficiency. So the person is unable to mount the right response to the vaccination. So once it is negative, what you want to do is to now immunize the child, because you want to give the child protection against pneumococcus. Right? Part of the management, you want to give them as much protection from vaccination as you can. So you now go and immunize the child. And then after a month, you have to do the vaccine responses again, because you want to see whether the child has now mounted a response. The initial not mounting a response may be a true immunodeficiency, or maybe that a child did not receive the vaccine, or maybe it's a spoiled vaccine, a vaccine that wasn't kept well in the cold chain. So you will not conclude on immunodeficiency just based on the first one. Based on the first one, you want to give the child protection. But then afterwards, you want to really see, now you have immunized, you are sure you have immunized. Has the child mounted a response? If not, at that time, you need to be talking to the infectious diseases people. And then sweat test. Again, just last weekend, Sandra and I were talking about a sweat test. We are still unable to do it. So even though worldwide is listed as the minimum panel of tests, we are still unable to do that one. But there are certain tests that we can use in lieu of the sweat test. But I would just like to emphasize again that at this point, or even before you get to this, once you do your full blood count, HIV, TB test, okay, please begin to talk to a pulmonologist or at least a pediatrician. Then there are other specialized tests that we can do. We can do in-depth immune tests to test for the to test that the child is immunocompetent. And we can do upper GI studies because we are looking for aspiration as the child is swallowing, tracheoesophageal fistula. We can do a milk scan because we are looking for reflux with aspiration. We can do an echocardiogram, maybe child has a congenital heart disease. We can do genetic tests for any of the things. It could be primary immunodeficiency, and that's you've gotten where you need to do a genetic test, or it can be that you are querying cystic fibrosis. It is rare, but it is there. It is really, really there. We are the ones not thinking about it. So genetic testing for that, or primary ciliary dyskinesia, ciliary biopsy. So these are other specialized tests that we can do. So in summary, what I would like us to take home is that if you think bronchiectasis, please consult a pulmonologist. And the pulmonologist doesn't have to be in your facility. You can just send a message, or at least discuss with your pediatrician. And there are mandatory tests to be done, a full blood count, HIV tests, TB tests that you need to do. Thank you very much.
Thank you, Dr. Sarah. Thank you very much for taking us through this journey on investigating for chronic suppurative lung disease. We've learned a lot. So at this point, we will call on our last, but definitely not the least of all the presenters, Dr. Osman. Kindly bring everything home for us for the last presentation. Then we would start the question and answer session. I see that Naomi has already started answering questions in the chat box, so you may share your questions in the chat box. The presenters who have already presented will answer as we go along, and then at the end, we would answer the others. Thank you.
Okay, thank you very much. I hope you can hear me and you can see my slides. Just want to have a response there.
Yes, please, we can. We can,
Okay.
yes. Please.
Great. So thank you to Dr. Ajete and Dr. Wadwi. And I don't know if it's Gabi that is speaking. Dr. Cranton, is that you?
Yes, please.
Okay, thank you, Dr. Cranton. So we'll end this presentation with the management of chronic suppurative lung disease. My main objective is to discuss management options that you can have for chronic suppurative lung disease. Mainly the outline will be talk about the role of airway clearance, the role of antimicrobials and nutrition and prevention. So some important points to consider is that with chronic suppurative lung disease, at some point you have to use antimicrobial, but you have to be very judicious in using it because it's not all the time that when they have this wet cough, that means they have infection. So if you have to use antimicrobials, you have to know exactly what to use, and we'll talk about that. Airway clearance is very important because most of the time, that is probably all that they need to help clear the airways. Then nutrition support and prevention is also important. So it's best managed by a specialist with expertise in pulmonary lung disease once you come to the conclusion that this child is having a chronic suppurative lung disease, either from HIV or from post-TB or any other condition that has already been discussed. Treatment and long-term management, your main goal is to make sure that you don't want them to have this race cycle of infection and inflammation going on for a long time, because when that goes on and it's not properly managed, it can lead to loss of lung function over time. They can develop either mostly they can develop restrictive lung diseases. So I'll start by talking about airway clearance. So airway clearance techniques are mainly non-pharmacological techniques that facilitate removal of secretions from the lungs. I think from Dr. Ajete's presentation, we learned about the mucus clearance that is very key for every healthy person. You need to clear your mucus, because if you don't clear them, then they get bacteria get stuck over there and they will cause infection. And this recurrent infections eventually will lead to chronic suppurative lung disease or bronchiectasis. So airway clearance is really important. And there are various forms of airway clearance, and we'll go through some of them. I've listed few here, so chest clapping, breathing techniques of huff coughing. Some of them the patient can do themselves. They don't need anybody to help them do. Some of them too, they may need help. Some of them are very expensive. Some of them are very cheap, like exercising and the huff coughing. They are cheap, and you can easily teach the patient to do it. So I'll start with chest percussion. So it involves striking the chest over the areas that you want to drain. Again, the aim here is that you want to help move mucus out of the lungs, so that they will either cough it out or they will swallow it. In little children, they may not be able to cough it out, but they will end up swallowing it. Because all this mucus, like has been said already, if they remain in the lungs, then they can cause infection. It should be done on a bare skin. Typically, you percuss each area for like 30 seconds, 30 to 60 seconds, and you avoid percussing the spine, the scapula, the clavicle. Whilst you're doing, patient should inhale slowly and deeply. Vibrate the chest as the patient exhales slowly through a pursed lip. And I have some pictures here to show. So if you are percussing the upper lobe, you let them sit like this. This is for an older child, but for a child, maybe 2 years or 3 years, a little child, you can sit them on your lap and do that easily. You can use your bare hand, like you cup your palm and use it to tap, or there are devices like this one that you can use to tap the back to do the chest percussion. So when it comes to the upper lobes, the anterior portion of the upper lobe, they can lie down and you can do both the upper and lower lobes by just clapping those areas. And remember, as you do, you let them take in deep breath, then slowly breathe out through a pursed lip. And that will help bring the mucus out, and either they cough it out or they swallow it. So you do this depending on how severe their situation is. They can do it once a day or twice a day, or in some situations when they're having increased sputum production, then we can let them do it as much as like 4 times a day. And it's the goal is to help remove secretions from the airway, which again, if it gets stuck, it can cause blockage of the airways, and it can also lead to infection and all that. There are also breathing techniques. These are also very effective when you teach them how to do it well and they are doing it well. It helps clear mucus from the airway. So it involves the thorax get expansion, which consists of deep breathing with inspiration and passive relaxed expiration. When you do that, you increase the airway diameter, and that loosens and dislodges any secretions. So this procedure, this technique, together with other techniques as well, they all prevent alveolar collapse and facilitate expansion of the lungs and peripheral airway clearance. There's also half coughing, which is also very effective in children with cystic fibrosis. That is one of the techniques that they are taught all the time to help remove mucus from the lungs, and children with bronchiectasis too, or other conditions like primary ciliary dyskinesia, or in our case, children with post-TB wet cough, like Dr. Wadu said. They may be coming with wet cough after you treat them with TB medications, and clearly at that time, it's not like they're having another TB, just post TB because the airway is compromised. They can be having these wet coughs. And by teaching them such techniques, such half coughing or breathing techniques can help them clear their airways so that the cough will reduce and they won't develop infections. So with half coughing involves taking a deep breath, holding it, they hold it for a few seconds, then they actively exhale continuously. And when they do that, it actually stimulates coughing. Then they cough. Those who can spit it out will spit it out. Those who can swallow, those who swallow will swallow. So it's a technique. Unfortunately, it's something that has to be taught, but I'm just bringing to your knowledge that there's such a condition. You can Google half coughing and you'll see how it is done. It's pretty simple, and if you do it well, it's very effective. So they can do standing or they can do sitting. So as you can see in this picture, when you're sitting, you inhale, taking a slightly deeper breath than normal. Then you exhale, holding your abdomen. They say if you hold your abdomen, then you can cough out. There are other airway clearance techniques, some using devices like this. This is called a cappella, and this is called aerobica. These are very effective so the child will be blowing through this device. And whilst doing that, they blow they blow against. So they're taking a deep breath, then they blow against a resistance, and this helps to loosen the mucus in the lungs, and then they will cough it out or swallow. The one you see on your right here is more mechanical. It's connected to a machine, and that is how it works. But these ones are manual, like the child will just take in deep breath and blow through it. So these are called positive expiratory pressure PEP devices or oscillatory PEP devices. And then we come to more sophisticated, more expensive devices, like you can see on this child, what we call the vest therapy or the high frequency chest wall oscillation. These are connected to machine, then it sort of shakes the chest and help loosen any secretions in the mucus, and then the child can cough it out. They are pretty effective. They use positive and negative pressure changes to augment peripheral tracheal mucous movement towards the opening airways. But they are very expensive. But like I've already mentioned, you can use non-expensive devices or non-expensive techniques. Even exercising, I didn't put a slide here, but just regular exercising for children that have chronic suppurative lung disease or bronchiectasis can help bring a lot of mucus out so that they don't get stuck in the airways and cause problems. There are other things that can be used, like hypertonic saline. These are more for children that with bronchiectasis that have an exacerbation, that are very sick. Maybe they are having a lot of mucus production. They are having a lot of mucus production. They are in respiratory distress. Their saturations are down. They're having fevers, and for some reason they get hospitalized. Then the hypotonic saline is one of the treatments that can be given. It helps loosen the mucus so that they can bring it out easily, because sometimes it gets thick. In cases like bronchiectasis, it gets very thick, and bringing it out may be difficult. But it can cause bronchospasm, the hypertonic saline. So most of the time when it's being used, it's used with albuterol. You give the albuterol first to open up the airways before you do hypertonic saline. And albuterol, the albuterol also actually is known to help move the ciliaries as well. But these are treatment that should be done by somebody with expertise in managing such children. Then we come to the role of antimicrobials. Ideally, if your airway clearance therapy is working well with children with bronchiectasis or other chronic suppurative lung disease, then you may not need any microbial, but sometimes there may be the need to do microbials, antimicrobials. Ideally, you want to do a culture, a sputum culture, before starting any antimicrobials, which the sputum culture, in some places, you can just do a nasopharyngeal swab to do a culture, or if the child can spontaneously bring out a sputum, or in places that they can do induced sputum, then the advanced form would be the bronchoalveolar lavage that Dr. Wadu talked about. That is more going into the lungs to take sample. That is the most, should I say, more, it will give you a better sample, but it's an invasive procedure, and we don't have the expertise to do that more easily in Ghana. We should remember that if you know the cause of the wet cough, the cause of the chronic suppurative lung disease, then you should treat if you know the underlying cause. So a child with HIV, you should make sure that they are taking their ARTs, their CD4 counts are appropriate, because by just treating the HIV properly, the wet cough, the chronic cough will probably go away, and you don't have to do anything else. The same with TB. In post-TB children, maybe airway clearance, you should make sure that they are doing proper airway clearance, because if they are presenting wet cough, it's not all the time that it doesn't mean that their TB wasn't treated. It's just an after complication of the TB. But in some places, they may also have bacterial superimposition. So in that case, if maybe they are presenting with fever and other respiratory symptoms, low saturations, and stuff like that, you have to then treat with appropriate antimicrobials. So in terms of treatment, sometimes they may have mild exacerbation. That is, the child always has some wet cough. Maybe you call it baseline wet cough, but then the mother brings it because the child is having fever and coughing more than normal and bringing a lot of sputum. Based on your evaluation, if the child is not that sick and can be treated outpatient, then you can start some outpatient antimicrobials, because you don't want it to get worse. So amoxiclav is a good choice for initial, because it covers most of the respiratory bacterials. But in some situations, they may be severe. So again, the situation where the child has this chronic wet cough, but they are going about their daily activities. Everything is fine. They have bronchiectasis, but they've not had any severe symptoms, but now coming with fevers, coughing a lot, and difficulty breathing and all that. And if you deem the child needs to be admitted, then most of the time, if you're admitting them, you have to think about doing IV antibiotics. And I mean, the right protocol is probably treat them for 10 to 14 days of IV antibiotics. And if you're admitting them, they are very sick to the extent of maybe needing even an ICU admission, then you should be thinking about Pseudomonas coverage. And Dr. Wadi did mention a case like that. So it's something you should be thinking about because those children with bronchiectasis are prone to Pseudomonas infection when they are that sick. So you should make sure that you are covering the antibiotic coverage has Pseudomonas coverage. And then in that case, if they're admitted, you should be doing intensive airway clearance as well. So maybe 3-4 times a day, they should have either the chest clapping or they should be doing the PEP therapy or something to help clear the airways together with the IV antibiotics. That's how you can get them better. Then I just want to talk about the role of azithromycin. So azithromycin, as we know, is an antibiotic, but it also has an anti-inflammatory and immunomodulator properties as well, which can, in children that have bronchiectasis or chronic suppurative lung disease that are coughing all the time and they're having frequent exacerbation. Now there are studies showing that if you put such children on low dose 3 times weekly azithromycin, it can help reduce the frequent exacerbation. Again, this is not to mean that you should put every child that is having wet cough, chronic wet cough on azithromycin. It's better if you, for such things should be initiated by either the pediatrician or the pulmonologist. But I just want to bring to your knowledge that there's such treatment there where you can put them on low dose azithromycin to prevent frequent exacerbation. So think of a child that you have diagnosed with bronchiectasis or a child that maybe has a wet cough from other illnesses that maybe even we don't know the exact cause of the chronic wet cough, but they are coming frequently with fevers, more sputum production, needing oxygen and all that. Then in that case, you can give a trial of putting them on the azithromycin to see if that will help the frequent exacerbation. Nutrition is very important. You should make sure that such children who are having the chronic wet cough, bronchiectasis that you think, that you should make sure that they are having good nutrition, monitoring their growth, and because it's all part of the management process. Vitamin D deficiency is known to be very common among such children. So make sure that you're checking the vitamin D level, and if low, make sure you are treating them. If you're not able to check the vitamin D level, I think you can just put them on vitamin D to make sure that they are getting enough of that. Prevention is very important. Dr. Wadi touched on that. So if they have been treated, they have been diagnosed with any chronic disease, make sure they are getting their treatment properly. Avoidance of environmental irritants is very important. So if they are in a place where they are exposed to a lot of smoke, people burn their rubbish around. For such children with bronchiectasis or chronic wet coughs, you should make sure that they are avoided. If there are smokers in the house, make sure that they are not exposed to smoke. Vaccination is important. Make sure that they are up to date with their vaccination in places where there's influenza vaccines. It will be good for them to get, and COVID vaccines in the present times is also good, because anything that will any viral infection that can lead to lower respiratory tract infection will exacerbate their symptoms. So we want to make sure that we are getting them vaccinated and protecting them from such viruses or bacterial infection. So I think that is all that I have. I'll give it back to the moderator. Dr. Quartin or Dr. Quarantine, I am done. So
All right.
I don't know the
Thank
next
you
step.
very much, Dr. Osman, taking us through the management of chronic suppurative lung disease in children. Indeed, we've been enlightened with so many options, those we can use in our limited resource areas, and then those in the ideal setting. So at this juncture, we would ask for questions. You may show your hand, and then we'll allow you to unmute and then ask your question. You can also type the question in the inbox as well. Thank you.
I think there's a question in the box to me saying, when do you consult a surgeon in a child with bronchitis not responding to routine management? That's a good question. I mean, definitely one of the immediate indication that comes to my mind is if they start to have hemoptysis, then you should be talking to the surgeon because once they start to have hemoptysis, if not treated, I mean, if then you are thinking of maybe doing a lobectomy in that case, but it has to be, it's a decision that you have to make together with the surgeons to see if that will be indicated because if a major artery is touched, that can lead to profuse bleeding, and you don't want to get to that stage. So that would be my answer to your question. Thank you.
Thank you, Dr. Osman, for the answer to that question. I just want to add up a bit to that. As you rightly said, this must always be in consultation with the surgeon, and if you have a major bleed. But in addition, some children have missed or retained foreign bodies that have led to bronchiectasis. There are children who have maybe swallowed a pin or something, and because they are afraid that they may be scolded, they keep quiet. And then it sits there and can lead to bronchiectasis. So when that is identified, because it's a foreign body, because it is a foreign body that is limited to one side of the lung, it may be helpful. Sometimes the foreign body is so stuck that it can't even be removed. It's only via a lobectomy that can be done. So you take out that part of the lobe with the retained foreign body. Or sometimes the bronchiectasis is not a foreign body, but it is localized. And you do everything, but then the child is still pouring out sputum and it's not thriving and it's always sick. It may be better to just take out that portion of the lung where the sputum is sitting. It's like that portion of the lung is almost, you can think of it as just liquefied and it's there and it's spilling over to the other lobes of the lung and rather causing the other lobes to be diseased. So in very localized bronchiectasis like that, it's worthwhile consulting the surgeons, and sometimes the best decision will be for them to reset that lung. But because our etiologies are usually infective, you see that we have like diffuse bronchiectasis. In that case, because we can't remove the whole lung, that may not be warranted.
Thank you. I think there's another question. Dr. Osman, Dr. Ananibimpo is asking you to go over the exercises again. I'm not too sure if it's all
Yeah,
of
so the
them.
exercises are not any particular exercise, but just aerobic exercises. Just aerobic exercises are even enough to help clear your airway. So they are not any particular exercises. I don't know if that is what the answer she's wanting. So there are not any particular exercises for airway clearance, but just aerobic exercises are enough to help move secretions in the lungs.
Okay. Then I don't know if there's any other question I've missed. The questions are moving quite. Naomi, I think you're answering a lot of questions in the chat box. Could you perhaps read the last two or so you have answered so that we can all learn from it? It's moving very fast.
Which one is it? Let me see. So the last two, I think the one someone asked about the upper respiratory tract infections and for the definition of recurrence, how many times within a certain period will the presentation of a wet cough then become a cause for concern? And so the difference with us, like I put in the answer, for chronic suppurative lung disease, they'll have a wet cough, but with upper respiratory tract infections, typically they will not have a wet cough. They can have like cough for a prolonged time. Okay, sometimes the cough reflex becomes hypersensitive. They cough a lot while recovering from upper respiratory tract infections, but usually it should resolve before 4 weeks. Okay, and especially in case who are impressed, you see that they are recovering from one and then they get another one. Okay, I think that is what she's trying to, if I'm getting her right. Those ones will not have a chronic wet cough, and they'll have the upper respiratory tract symptoms, rhinorrhea, like cold-like symptoms, which is not typical for chronic suppurative lung disease. I hope that answers the question.
All right, thank you. Thank you very much. Are there any other questions? Otherwise, we can take the next 10 minutes to get closing remarks from each of our presenters. Any takeaway message or take-home message, then we can wrap up and then close. Thank you. So we may start with Naomi.
Okay, so probably I would say the strong emphasis I want to make or for us to take away is the symptom of chronic wet cough, okay, especially when you have a child recurrent or prolonged. So this is not a child you want to just give antibiotics and then send away. Yes, give them antibiotics, but then see them again and see if what you started is working. Okay, so you keep following them up and then try as much as possible all that we have been want to help to prevent all the long-term issues. So if we can get them in, as Dr. Wadi said, in some cases we may be able to even reverse it. So we want to, as much as possible, prevent it or halt the progress. So please keep an eye on any child with chronic wet cough and then let's investigate. Okay, thank you.
Thank you, Dr. Sarah.
Thank you. So I really think that Naomi's part of the presentation is the most important. And so she has said what I would have said. With bronchiectasis, when you think about it, it's when you can diagnose it. And when you diagnose it early, then there is potential to save that lung. If I think about the patients with bronchiectasis that I have seen, they've had symptoms for years. So if only we thought about it early, and either they are stuck on oxygen or they have died. So I think let's think about it. Okay, chronic wet cough, think bronchiectasis, and asthma. You are in asthma clinic or you are seeing a child with asthma, and all of a sudden you see that the child has clapped. It has clapping of the fingers and toes. Asthma patients don't have clapping. So think about bronchiectasis, so that we can help that child. So it's early diagnosis for me, early diagnosis. Because when you diagnose, then you can refer. Yeah. Or suspicion, early suspicion, then you can refer for the workup.
Thank you very much, Dr. Asma.
Okay, so I would say that I mean, if a child comes in with chronic cough, you have to thoroughly investigate, and if you investigate and you find the underlying cause, treat it. But like Dr. Ajeti said, after treating, follow the child because it's a spectrum. So if the child continues to have this chronic wet cough, it's not every time that you have to treat with antibiotics. Maybe it's simple thing like airway clearance, frequent airway clearance will help remove mucus from the airways so that they don't continue to have recurrent lung infections. In our setting, unfortunately, we are not able to thoroughly investigate and things like cystic fibrosis, but at least initiating airway clearance and identifying exacerbations and treating with appropriate antibiotics is enough to prevent disease progression to the stage of where they probably have bronchiectasis and can lead to the other end of the spectrum where maybe they will have to have a lobe taken out. So monitoring is really key, and always get a pediatrician or a pulmonologist involved in the management of such children. It's very important. Thank you.
Thank you very much. Thank you. And thank you to our amazing audience for staying to the end and for all the questions and contributions that you have made. So we've
I
we've
think
come to the end.
earlier
Okay,
I saw
Naomi.
Dr. Afel's hand up, but I'm not sure.
Oh, okay. Dr. Hoysel
Okay, it's down now. Dr. Afel.
is that. Okay.
Okay.
Okay. So we've come to the end of this.
Dr. Gabby,
Yes,
Dr.
please.
Gabby,
Yes.
apologies, please. There's a question on YouTube.
Oh,
If I could read it out, please.
yes, please. Yes, please.
Please, there it says, do children come with conditions that require surgery? If so, how are they managed with regards to anesthesia?
Okay, so anyone can take this. It's a question on YouTube. So we have viewers who are also watching.
Yeah, the question is not clear. I don't understand what the person means by do they come with. I mean, if Naomi or Serum understand, they can go ahead and.
I'm trying to understand. I'm thinking the person wants to know if such children have surgical conditions and they need surgery. How is anesthesia? I don't know if
So I think that question is best answered by the anesthetist. So far in Polybu anesthesiologist, yes. So far in Polybu, I haven't had a child with bronchiectasis managed surgically. However, from my experience during my training, especially when we are doing retained foreign bodies with bronchiectasis, I think the anesthesiologists just have to take into consideration how ill the child is, consider whether that child surgery will benefit the child. Like, Is that are we going to lose the child through our intervention, or it is better we try and intervene because that is what is better for the child? And they still go ahead and anesthetize anyway. Sometimes you have complications, but before you do that, the team is ready and knows there can be complications. You have ICU ready and all that, so it can be managed. Sometimes it goes well. Yeah, but I think us not being anesthesiologists, I don't think we will give a very good answer to that question.
Yes, please. Thank you. I think it will be on a case-by-case basis. And so, like you rightly said, based on their experience and what they know about the child, they'll be able to decide which type of anesthesia or if the child can even undergo anesthesia at all. So thank you. And we've come to the end of this continuous medical education and PhD.
Dr. Isel said he needs to be unmuted.
Unmuted. Oh,
I don't
okay,
know
okay.
if
Yes.
Oh, unmuted.
So yes, hello.
Okay.
Thank you very much. Good evening.
Good evening, Dr.
So
Isel.
yes, please. Yes. So I've been unmuted. Thank you very much, and thank you, the presenters. I came in late, but one of the things that struck me was the point Sarah made on the foreign bodies in the children who might have taken a swallowed some foreign body and then they would not report. I remember in 2014, we had a child on Team C. The child was referred from Tema. He's around 10 years, a very big, tall boy from Tema. Was referred because he had recurrent respiratory tract infection, especially lower respiratory tract infection. He had antibiotics, but this time, when he was put on antibiotics, he was not doing well. Temperatures were just spiking. So he was brought to S and we're on Team C. On Team C2, we started antibiotics. This child was not improving. And we wanted to go further to investigate. We did one X-ray. We said that there was something that looked like a foreign body over there. So we went ahead to do a CT scan, and then we saw all this honeycomb appearance over there. In fact, let me cut my story short. That boy ended up losing the lung. So I was so happy when Syrian brought it up that we should be asking for. So yes, we might be having infections, but in our setting, some of these children too are around and they will not tell their parents, and this will go on for a very long time. And that's what actually happened to this child. He was afraid to tell his parents, and it was actually an office pin. In fact, I have that office pin with me, a picture with me on that. Thank you very much.
Very good share, Dr. Isel. Very good. Thank you.
Thank you. Thank you. Thank you. And thank you to the Pulmonolgy subspecialty team for all your wonderful lectures you have organized throughout the whole year. It's been very enlightening and very educative. So next week, Monday, we have another CME, this time on HIV. As you are all aware, or you may not be aware, Sunday is World AIDS Day. And as part of the celebrations, the Special Clinic at Kolebu Teaching Hospital Child Health Department is organizing a CME. They are also 20 years old, and so it's a double celebration for the team there. And so we would ask that you all register for that CME and then also be enlightened and educated on the app or what is up with HIV, and particularly managing HIV in children. The last thing we will do in PSG for the year is going to be advocacy on gender-based violence. So starting from Monday, we started, the whole world is creating awareness on gender-based violence. It's known as the 16 days of activism against gender-based violence, protecting our children and women who are abused. And so in the coming days, you may see some posters and educative information on that as well. And then we'll round up the year with that. So thank you once again for joining us. And I hope you have all filled the evaluation form. It's very important for us to.
Yes, Gabby, just before we go, this is Dr. Opon.
Okay,
Yes, so
Emmanuel.
let's know that this Friday, 4 p.m., the second CPD for the Prematurity Awareness Month comes off. So let's take notes. This Friday at 4 p.m., the second CPD for Prematurity Awareness Month. The poster and the links will be shared. Thank you. and over.
All right, thank you very much. So the Ashanti group would be leading us with that as well. That's a lot of opportunities for us to learn, and we hope that we are all able to make it worth the while. So thank you once again and have a good evening. Bye.